Hello, everyone. Welcome to the CDC Division of Healthcare Quality Promotions Tune In to Safe Healthcare webinar on the 2024-2025 respiratory virus season updates for long-term care providers. Our presenters today will be Dr. Evelyn Twentyman, who's a Senior Advisor for Vaccine Strategy for the Immunization Services Division in the National Center for Immunization and Respiratory Diseases. Dr. Pregna Patel, Chief Medical Officer for the Coronavirus and Other Respiratory Viruses Division in National Center of Immunization and Respiratory Diseases. Dr. Erica Wallander, a medical officer, that's me, in the Division of Healthcare Quality Promotion in the National Center for Emerging and Zoonotic Infectious Diseases. And our Q&A moderator today is Dr. Kara Jacob-Slifka, the Long-Term Care Team Lead in the Division of Healthcare Quality Promotion in the National Center for Emerging and Zoonotic Infectious Diseases. Before we begin, I have 3 disclosure slides to show related to the CE that's being offered through CDC's Train Learning Network. We will advance through them slowly to allow you time to read. The first is the following accreditation statement. This webinar is accredited for several types of CE, including CME, CNE, CEU, CHES or MCHES, CPE, and CPH. I will now share with you the following disclosure statement. Please take a moment to read. And this is the joint accreditation statement for pharmacy education. Again, please take a moment to read. And that concludes our CE disclosure slides. And we'll jump in with some background on respiratory viruses in long-term care. We wanted to start our presentation today by recognizing how COVID-19 caused unprecedented losses of life and sacrifices by residents, their loved ones, staff, and facilities in those first years of the pandemic. As you well know, the weekly deaths among nursing home residents related to COVID-19 reached over 6,000 per week nationally in December of 2020. And through the efforts of so many and the evolution of the pandemic, we have seen the burden of COVID-19 related deaths among nursing home residents decrease dramatically, though it hasn't disappeared. During last year's respiratory virus season, weekly deaths among nursing home residents with a recent positive SARS-CoV-2 test peaked at 339 in November of 2023. In addition, while other respiratory viruses diminished during our isolation in the early years of the pandemic, we have seen viruses like influenza and RSV return. And now, although nursing home and assisted living residents make up just 2% of the US population that's over 65 years of age at any given time, last respiratory virus season, nearly 20% of hospital admissions captured in our COVID and RSV surveillance systems were among long-term care residents. And in the National Health Surveillance Network data, nursing home residents had up to 8 times greater rate of COVID-19 related hospitalizations compared to US residents 70 years of age and older. We also know that individuals over 65 years of age have the highest risk of influenza hospitalization. What is contributing to this disproportionate risk? Well, we know long-term care residents are at high risk of respiratory virus infection due to living in group settings with communal activities. And long-term care residents more commonly have risk factors for severe respiratory illness, such as older age, in particular those over 75, diabetes, chronic kidney disease, chronic lung disease, coronary artery disease, and stroke. Based on the data available, we are predicting a US respiratory virus season for 2024 to 2025 to have a similar severity to last year. Since COVID-19 continues to circulate, We expect the burden of severe disease due to respiratory viruses to continue to exceed the levels of in the pre-pandemic years. And as we still have regularly reported data on COVID-19 related hospitalizations among nursing home residents, we do see that similarly to last year, hospitalizations among residents with a positive SARS-CoV-2 test have already begun increasing this year, with similar to higher numbers of hospitalizations in July and August of this year compared to the same months last year. Since we expect long-term care residents will remain at higher risk of severe respiratory illness this fall and winter, our objectives today are to share the tools we have to prevent severe respiratory infections among long-term care residents, and we aim to describe the eligibility criteria for the 2024-2025 COVID-19, our seasonal influenza, and the RSV vaccines, communicate key benefits and side effects of each respiratory virus vaccine, identify eligible individuals for COVID-19 and influenza treatment, and summarize key infection control and prevention actions. And now I'll hand it over to Dr. Twentyman to discuss respiratory virus vaccines.
Thank you so much, Dr. Wallender. My name is Evelyn Twentyman, and I'm super happy to be here speaking with you all today. I am so grateful for the work that you all do to keep long-term care facility residents healthy. I'm sure you all have heard this about a million times before, but seriously, you are the public health heroes here in your dedication to your populations and your determination to get the people you serve really protected as we head into another respiratory virus season. So truly, thank you for all of the work that you do, first and foremost. Now, what I'm going to do here with you all today is to discuss our respiratory virus vaccines. What we'll discuss is first our recommendations, in other words, who should receive what vaccines and when, why vaccination against respiratory viruses is so important, and then thirdly, what we can do together to encourage long-term care facility residents to get vaccinated. And next slide, please. Thank you. I do want to start with the headline here, though. We're talking about these vaccines here today because these vaccines cut the risk of severe disease by half or more. COVID-19 and influenza vaccines cut the risk of hospitalization in half in all ages. And additionally, COVID-19 vaccines are the best available protection against long COVID. RSV vaccines prevent older adult RSV hospitalizations and result in more than 3 times lower risk of those hospitalizations. So if you can get your residents these vaccines, that's a huge win that you've accomplished. Next slide, please. Okay, let's start with recommendations. Who needs what vaccines? For COVID and flu, this is super simple. Everyone ages 6 months and older needs a COVID and an influenza vaccine every year. Our adults over age 65 can also benefit from a higher dose or adjuvanted flu vaccine if they're available. And then for RSV, we protect our infants through either infant immunization with nirsevimab or maternal vaccination with RSV vaccine. Adults ages 18 to 59 who are not pregnant don't need an RSV vaccine, but those ages 60 years and older with risk factors, and we'll show you what those are, do benefit from a lifetime dose of RSV vaccine. And all adults ages 75 and older are recommended to receive 1 lifetime dose of RSV vaccine. Next slide, please. This slide shows you the recommended timing for each of these vaccines, but let me give you just the headline here. For older adults, the time for COVID, influenza, or RSV vaccines is now. Go time is now to get our older adult residents protected against these viruses. If you have residents that either can't or won't be vaccinated now, or as you admit, new residents who haven't had these vaccines, do continue to offer them throughout the year. Next slide, please. Here are the risk factors that indicate recommendation for your residents over the age of 60 to get RSV vaccine. As you can see, almost any chronic condition associated with end organ damage indicates that they could benefit from these RSV vaccines, as well as residents in a nursing facility, which is certainly relevant to folks on this call, as well as moderate or severe immunocompromise, or other factors that you think could increase risk of severe disease, such as frailty. Next slide, please. Before we move on from our recommendations, I do want to mention that older adult populations also need to be protected against other diseases like shingles and pneumococcal disease. In the US, about 1 million people have shingles every year, and 1 in 3 people overall will have shingles in their lifetime. And unfortunately, those complications increase with age. So all adults ages 50 years and older should get 2 doses of the shingles vaccine. And then on the pneumococcal disease side, pneumococcus is a leading bacterial cause of pneumonia in adults, with more than 100,000 US adults hospitalized every year. Adults with certain medical conditions like chronic heart or lung or renal disease are at higher risk. So overall, those adults ages 65 plus and those with risk factors should get a pneumococcal conjugated vaccine. Next slide, please. So now that we've covered our vaccine recommendations, let's turn to why we recommend these vaccinations and why they're so important for your residents. First, we'll discuss all respiratory virus disease vaccines together, and then we'll discuss the importance of COVID, flu, and RSV vaccines individually. Next slide, please. We immunize because it's our best defense against viruses that can cause serious illness. Thousands of people are hospitalized for COVID-19, flu, and RSV each year. Adults ages 65 plus are 4 to 9 times more likely to be hospitalized for COVID, flu, and RSV than those under age 65. But fortunately, COVID-19 and influenza vaccines cut that risk of hospitalization in half, and RSV vaccines are more than 70% effective at preventing older adult RSV hospitalizations. Next slide, please. Now let's discuss the importance of COVID-19 vaccines specifically. What you're looking at here is the percentage of hospitalizations with COVID-19 by vaccination status and by age group. The yellow bars jump out at us here because unfortunately, that's the higher risk group, those without the protection of the COVID-19 vaccine. So we encourage you to encourage your residents to reduce their risk of hospitalization with COVID-19 by getting a vaccine. Next slide, please. In addition to the risks of hospitalization and death from respiratory viruses, long COVID is a chronic condition lasting 3 months or longer. This can develop after infection with SARS-CoV-2, the virus that causes COVID-19. Overall, 3.4% of adults reported long COVID in 2022, with a quarter of those individuals continuing to experience impacts in their daily lives. We know that long COVID occurs more frequently among groups at risk for severe illness and individuals without the COVID-19 vaccine. So this is another really good reason to get the COVID-19 vaccine. Next slide, please. We also wanted to offer you some points for your residents about why to get another COVID-19 vaccine this year, in case that is a question that comes up to you from them. Okay, here's the problem. The virus that causes COVID-19 is always changing. Fortunately, this is also why we make sure the vaccine is updated every year. So your residents' protection is best if they've received the vaccine most updated for the most recent version of the virus that causes COVID-19. Additionally, protection of these vaccines wanes over time. So we want to boost that protection every year. And we see that this works. People who received last season's vaccine saw greater protection against illness and hospitalization than those who didn't receive that vaccine. And to provide just some important reassurance, getting another COVID-19 vaccine this year is safe. Hundreds of millions of people have safely received these vaccines under the most intense vaccine safety monitoring program in US history. Okay, having discussed COVID, let's move on to flu. Next slide, please. Perfect. So as you can see, older adults also have a much higher rate of hospitalization with flu. And as we've discussed, flu vaccine is our best protection against hospitalization with flu. So let's get those wins made too. Next slide, please. And why vaccinate older adults against RSV? Because their risk of hospitalization with RSV rises with age. And you can see this really steep rise in adults ages 75 years and older, but having received the RSV vaccine cuts this risk for them. Next slide, please. And I can't conclude our discussion of the importance of these vaccines without saying that, unfortunately, Despite these benefits, many residents are missing out. By the end of last year's respiratory virus season, fewer than half of them had received at least one COVID-19 vaccine, fewer than a quarter of them had received an RSV vaccine, and just under 3/4 had received a flu vaccine. And keep in mind that this is despite the universal recommendations for annual COVID-19 and flu vaccines. So we have a ways to go. Next slide, please. So given that ways to go, what can we do to encourage vaccination? Next slide, please. Well, to start with, we can start by thanking you for the enormously beneficial influence that you can have on your residents. If you're a healthcare provider working in a long-term care facility or otherwise serving long-term care facility residents, just know that you are your residents' most trusted source of information on vaccines. They care what you think. And we know that you care about them because you're here today. So thank you for everything that you're doing to encourage their vaccination. Next slide, please. Strong provider recommendations, in other words, recommendations from you, can increase resident confidence in vaccines. In making your recommendations, you can be specific, be clear, be attentive to their concerns. And if they don't accept vaccination after one discussion, don't give up. Try again later. If a resident or family member declines vaccines once, it doesn't guarantee they always will. Continue the conversation. Next slide, please. Here, we're showing you the benefit of continuing the conversation. This study that we're showing you right here showed us that some patients needed to be offered the COVID-19 vaccine up to 11 times before they decided to be vaccinated. So don't give up, continue that conversation, and it can have benefit for your residents. Next slide. And now let's consider some logistically beneficial strategies. You can definitely co-administer these vaccines. You can give them at the same time. Residents may experience more mild side effects such as fever and fatigue, but these are usually mild or moderate and last just 1 to 2 days. And if a resident prefers to wait to receive these vaccines during different visits with you, just rest assured that there's no minimum waiting period between vaccine doses. Next slide, please. Lastly, we just wanted to leave you with some resources toward ordering and offering vaccines in your facility, recommending these vaccines, and offering early treatment for COVID-19 to your residents at risk. So thank you again so much for your time, for your attention, your work to protect your residents through this respiratory virus season. And speaking of treatment, I'd like to turn the floor to Dr. Pragna Patel to discuss testing and treatment. Dr. Patel, over to you.
Thank you so much, Dr. Twentyman. So we're going to shift a little to testing and treatment. Next slide. And in the interest of time, I'm not going to delay going through these. So basically, I'm showing this slide because we've done some data analysis looking at use of antivirals and monoclonal antibody treatments in nursing homes. And what we're seeing, if you look at the graph on the left, that orange line is basically showing the residents that have COVID-19 cases. And the gray-green line is showing how many of those residents received treatment. And so overall, the treatment rate was about 18%. It peaked at 33% in November, just after Thanksgiving of 2021. But you can see that this uptake is incredibly low. And if you just look at the slide on the right, this is basically showing you what kind of treatments were used among residents. And you'll see, looking at that gray-green line, that nirmatrelvir, ritonavir was overwhelmingly the most common treatment that was prescribed at 60%, and about 18% received molnupiravir. So there is a lot of room to increase the use of treatment, and in a little bit, I'll go over why this is so important. Next slide. There have also been other studies in other populations that have shown underutilization of antivirals, and I just wanted to share a few of those studies here with you. There was one that was published in the MMWR that looked at veterans, and they reported that about 25% to 30% of veterans who are eligible for treatment are actually receiving treatment. And then there was another MMWR that looked at the general population and found that there was low levels of uptake, especially in socially vulnerable groups. And then for flu, we're noticing that in the pediatric population, there's a low uptake of treatment. Next slide. And so this slide is a little bit busy. Let me take a minute to orient you. If you look at these graphs on the y-axis, we're really looking at the reduction in hospitalizations. And I want to just point your attention to the slope of these lines because each line basically represents different uptake of nirmatrelvir, ritonavir, which is commonly known as Paxlovid. And what this modeling study showed was an increase of uptake of antiviral use to 80%, which is that light gray line at the top with the steepest slope, resulted in reductions in hospitalizations and deaths by 42% and 51% respectively. So you can see that if we can increase treatment uptake among residents above 30%, Model 7, which is the next line, the gray-green line, is Paxlovid uptake of 40%, still a nice increase in slope for both hospitalizations and deaths. We really could decrease the number of hospitalizations and deaths among residents. And I will say that the modeling group did look at nursing home residents separately, and they saw that the improvements were even higher when you just focused on nursing home residents. Next slide, please. So I just wanted to talk a little bit about testing because testing can be very important. One, it can increase access to treatment. Getting tested can help you get treated sooner, and treatment is likely to be effective when started early. So it's really most important for people who are at higher risk of severe illness, such as older adults and residents of nursing homes, to get tested when they do have respiratory symptoms and they're worried about either influenza or COVID-19. I just want to reiterate that a documented positive test for SARS-CoV-2 and for flu are not required to initiate treatment. And I'm pointing this out because when the COVID-19 antivirals were under authorization, a positive test was required. But since nirmatrelvir, ritonavir, and remdesivir have been approved, and a positive test is not required. And then just to let everybody know that U.S. households will be again eligible to receive free COVID-19 tests starting in late September, so very soon. And CDC has a program called ICAT, which is offering free testing to people who are underinsured, uninsured. And so we do encourage folks to look at the ICAT website to see where they can go to get a free test if they need one. Next slide. And I wanted to just talk a little bit about testing and treatment and models for testing and treatment, because these have been shown to be very effective in other settings and could be models that could be implemented in nursing homes, particularly during respiratory virus season, just to help residents get treatment as soon as possible to keep them out of the hospital. So essentially, if an individual has respiratory disease symptoms, we're encouraging you to think about COVID-19 and influenza and RSV. We have treatments for COVID-19 and influenza, and so it's really important to at least test for these two pathogens. There are singleplex tests available and multiplex tests available, and I'll talk a little bit more about those multiplex tests in a little bit. And we encourage patients who test positive for either SARS-CoV-2 or influenza to be evaluated for their eligibility for treatment and ensure that patients who do test positive and who are eligible get treated as soon as possible. Next slide. And so let's just talk a little bit about multiplex testing. So essentially, multiplex tests simultaneously analyze samples for multiple pathogens, and there are many SARS-CoV-2 influenza multiplex tests available now. Most of them are lab-based, but there are some over-the-counter tests that have been authorized for home use, and the link at the bottom of the page can give you more information about these tests. And we think that they can be a really powerful tool for treatment because patients do present with similar symptoms if they're infected with SARS-CoV-2 and influenza, and knowing which pathogen they are infected with can help guide specific antiviral treatments. And then there's the added benefit of early detection, helping to reduce further transmission, particularly within nursing homes where outbreaks tend to happen. Next slide. So what are the advantages and disadvantages of different tests? So just drawing your attention to the column on the left, there are two main types of tests. There are nucleic acid amplification tests that are often also referred to as molecular tests. Also, PCR tests are the most common type of NAT tests. And then there are antigen tests, and those are the tests that we can use at point of care and at home. And the advantage of the NAT tests are they're really the most sensitive tests available. They give you probably the best results. They're considered a gold standard, and you don't need to repeat this test or confirm the results because of that. The antigen tests are advantageous because of the short turnaround time, but also you can perform them pretty much anywhere, and they're more cost effective. The disadvantage of the nucleic acid tests are they do require a longer turnaround time, 1 to 3 days, so that could shorten the time to get treatment. That could lengthen the time to get treatment. They cost more. And for SARS-CoV-2 specifically, they can stay positive for a very long time in certain patients. The disadvantage of the antigen tests are that they're less sensitive and more false negative results can occur with antigen tests. And so if you do have a high index of suspicion for SARS-CoV-2 among a patient who tested negative with an antigen test, that test should either be confirmed by a NAT test or repeated. And the FDA does recommend repeat testing, and I've provided the link where you can get more specifics about that here. Next slide. So moving on to antiviral therapy, it's really an important tool for clinical management. As I've said before, it can reduce the risk of hospitalization for COVID-19 significantly, and it can reduce the risk of influenza complications, as well as reduce the severity and duration of illness. Decisions to start treatment are usually based on risk for severe disease, and I want to just call your attention to the slide that Dr. Twentyman showed about risk for RSV. The same factors are usually considered for risk of severe disease due to influenza and COVID-19. And it's not necessarily symptom severity that we look at when we decide who to treat. So for COVID-19, especially if someone presents with a mild illness, we encourage you to definitely think about treating them. And for influenza, if somebody is at high risk and has mild symptoms, you should certainly think about treating them. And again, it's recommended as soon as possible for any patient with suspected or confirmed COVID-19 and flu who have higher risk of complications. And when I say suspected COVID-19, I mean somebody who does have symptoms and has a history of an exposure. I want to point out that nirmatrelvir ritonavir is not approved for post-exposure prophylaxis. So if a patient has a known exposure but no symptoms, they're not eligible for antiviral therapy for COVID-19. Next slide. So who's at risk for COVID-19 and influenza? So you'll see the list is fairly similar to RSV. The age cutoffs are a bit different, but essentially older adults, especially adults greater than 65 years of age, younger children, especially those who are less than 2 years of age, people with weakened immune systems, people with any chronic conditions such as heart and lung disease, people with disabilities, pregnant people, some racial and ethnic groups because of many factors, and that really involves limited access to vaccines and healthcare, and then of course, residents of nursing homes and long-term care facilities who also tend to be older. Next slide. So just a brief overview of COVID-19 treatment. I'm focusing here on outpatient therapy. We're not going to go through inpatient therapy today. There are two main recommended antivirals for COVID-19, nirmatrelvir ritonavir, also known as Paxlovid, and remdesivir, also known as Veklury. There's an alternative therapy, molnupiravir, if these two are not available. So the age for Paxlovid is 12 years and above, and remdesivir 28 days and above. And the main reason that nirmatrelvir ritonavir is used most commonly is because it's the only oral recommended antiviral that's available. And remdesivir having an IV administration does create some complications. The other thing to note about nirmatrelvir ritonavir is that it's not recommended with severe kidney or liver disease. So it's important to know what a patient's kidney and liver function is. And you do need to check for drug-drug interactions, which may be very important in older populations who are residents of nursing homes. Next slide. And then just briefly wanted to also go over the recommended influenza treatments for outpatient therapy. Oseltamivir has been around for a very long time. It is available for persons of all ages, and baloxavir is available for patients who are healthy and 5 years and older, and then also high-risk patients who are 12 years and older. And both of these are the recommended oral influenza treatments that are available. One thing to note about baloxavir, though, is that it's not recommended for pregnant people or postpartum persons. And then there are two other options that are less commonly used in the outpatient setting, peramivir and zanamivir, mainly because of the route of administration. Next slide. So also I wanted to just share some resources with you. Next slide. CDC conducted some surveys and found that low uptake was due to some concerns about drug interactions with nirmatrelvir, ritonavir in particular. So I wanted you to be aware that we do have some resources that help clinicians understand which drugs can be safely used with nirmatrelvir, ritonavir. This Liverpool drug interaction database is a really nice an easy way to check for interactions. And then the FDA does have some website resources that I'm sharing with you here. Next slide. The CDC did write an MMWR about rebound because there were concerns both from patients and providers about rebound. We want you to know that rebound should not be a reason to withhold antiviral treatment among high-risk individuals for COVID-19. Next slide. And then here are some resources for how you can get the COVID-19 antivirals. I know people have a lot of questions about this because these medications were just recently commercialized. There are a number of patient assistance programs, including a US government patient assistance program, and everyone should be able to access these medications if they need them. And so I hope you find these resources helpful. Next slide. Again, a few links that you can refer to when you have more time. And next slide. And now I think I'm passing the mic over to Erica Wallander, who's going to talk to us about infection prevention and control. Over to you, Dr. Wallander.
Thank you so much. So infection prevention and control will shift gears, like Dr. Patel mentioned, to IPC, and IPC measures help prevent the spread of infections. When someone with a respiratory virus infection coughs, sneezes, talks, or breathes, they release viruses which can be spread to others through the air when they're inhaled and deposited along the respiratory tract. Viruses can also land on surfaces or objects, and people can become exposed if they touch those surfaces and then touch, for example, their mouth, nose, or eyes without cleaning their hands. Unfortunately, some respiratory viruses can spread even when a person with the infection does not have any symptoms. IPC measures reduce respiratory virus spread by preventing contact with viruses. And important IPC measures for respiratory viruses include practicing respiratory hygiene and cough etiquette, which includes wearing a mask for source control or covering your cough if a mask can't be worn, and frequent hand cleaning. Use of appropriate personal protective equipment or PPE based on standard and transmission-based precautions. Staying away from others when you are ill and ventilating shared spaces. and regularly cleaning and disinfecting surfaces in the environment. Within a facility, IPC resources, policies, and education are needed to help protect residents, staff, and visitors from respiratory virus infections. Today, we'll talk about how facilities and providers can prepare for increased use of respiratory virus IPC measures during fall and winter by allocating resources for IPC, educating residents, staff, and visitors, monitoring community spread, and ensuring appropriate facility ventilation. We'll then talk about how to respond when a resident develops respiratory symptoms, including use of transmission-based precautions, testing and treatment, and contact investigation. And finally, we'll briefly cover some time-limited enhanced IPC measures that can be used when they're spread within the facility. Starting with preparation, during fall and winter months, we know respiratory virus infection risk increases for everyone. Having adequate accessible supplies of PPE will make it easier to adjust PPE for resident care when new symptoms develop. Adequate stock of face masks, N95 respirators, gowns, gloves, and hand sanitizer are examples of necessary IPC supplies. PPE and hand sanitizer should be accessible throughout the facility on both day and night shifts. In addition, staff should be properly fitted for N95 respirators via annual respiratory fit testing to maximize their protection. In addition to stocking PPE, it is important to identify how a respiratory virus and other laboratory tests, such as blood tests for kidney function, can be collected and results available within 24 hours. Rapid test results will be most beneficial when the pharmacy connections are also in place to ensure rapid antiviral access for a resident with COVID-19 or influenza. Although we've been dealing with COVID-19 for the last several years and are pretty familiar with the recommendations, we understand that each day there can be many competing priorities for facilities and staff, from implementing enhanced barrier precautions to sepsis awareness, for example. As a result, it is important to remind everyone who enters the facility about recommended respiratory virus prevention policies. This can include hanging posters describing respiratory hygiene and cough etiquette, or signs indicating when universal masking is in place. Annual staff refresher trainings around respiratory virus IPC measures like hand hygiene and proper PPE use can help ensure everyone feels comfortable implementing the recommended IPC measures. Another important aspect of preparation is to know when there is an increased risk of infection. Risk can vary geographically and by facility population, for example. Regularly monitoring local indicators of increased community or facility respiratory virus spread can help you increase prevention efforts when the risk is highest. Your local and state health department can help you determine which indicators best represent increased spread in your community. Some examples of indicators could include the number of facility cases in a week, the percent of emergency room visits for acute respiratory illness in your county, the number of respiratory virus cases, hospitalizations, or outbreaks among the state's nursing home residents, or other local indicators. When community or facility spread increases, action steps might include universal masking, supplemental measures to improve ventilation, or increased surveillance among residents and staff for respiratory illness. Finally, it is important to consult with your facility engineers to improve ventilation in resident and staff areas, including break rooms. This can include achieving 5 air changes per hour, developing policies around changing fan settings in rooms, and clearing blocked vents. Now that the facility is prepared for the season, we'll move on to responding to a resident's new symptoms, starting with a case example. Mr. Jones is an 85-year-old man with a history of Alzheimer's and insulin-dependent diabetes. He lives in a nursing home and shares a room with a roommate who also has dementia. It's January, and today Mr. Jones's aide notices he feels warm and has a new cough. No one else on the floor has symptoms. As soon as a resident's new symptoms are identified, several steps can prevent further spread. This includes placing the resident on appropriate transmission-based precautions, even before testing occurs. As part of transmission-based precautions, move the resident to a single room, or if a single room is not available, take steps to limit transmission in the room. An ill resident should not be placed with a new roommate unless both are confirmed to have the same respiratory diagnosis. Because a roommate could also become infected, they should not be placed with a new roommate. Also, use PPE recommended for the care of a resident with SARS-CoV-2 infection. By symptoms alone, we can't tell what is causing a resident's respiratory symptoms. The PPE used for SARS-CoV-2 protects against most common respiratory infections, and so we use that while waiting for test results. All residents should remain in their room, and if they have to leave the room, they should wear a mask if tolerated. Their roommates should also be encouraged to wear a mask whenever they are around others, just in case they also develop infection. Finally, we want to make sure to test the resident and investigate which close contacts might also benefit from testing and potentially antivirals. So how could this apply to our response to Mr. Jones's new symptoms? First, Mr. Jones's facility does not have a single room available, so the team places a HEPA filter in the room and separates the residents' beds as far as possible with a curtain placed between. A transmission-based precaution sign is posted outside of Mr. Jones's room, and a cart containing N95 respirators, gowns, gloves, and eye protection is placed outside the door. Mr. Jones is tested for SARS-CoV-2 and influenza, and close contacts, including his roommate and his aide, are evaluated for symptoms and for future testing. Reassessment of transmission-based precautions, contact investigation, and resident treatment should occur when test results are available. For example, Mr. Jones is currently on precautions for SARS-CoV-2, which means his providers wear an N95 respirator, goggles, gown, and gloves when caring for him. If his influenza test is positive and his SARS-CoV-2 test is negative, he will be transitioned to droplet precautions, which refers to use of a face mask. If the resident was coughing and sneezing, then you would also wear eye protection to protect your eyes from splashes or sprays as part of standard precautions. As soon as a resident develops symptoms, they should be evaluated for treatment. If there is a strong suspicion for either COVID-19 or influenza due to a close contact or facility outbreak, for example, empiric antiviral treatment can be started before the test results are known, and then they can be stopped if the test results are negative. In the case of Mr. Jones, if we do not have a strong suspicion for the cause of his illness, we can still determine eligibility, availability, and dose of both a COVID-19 and influenza antiviral treatment course. And when his test results return, we can start the appropriate antiviral quickly. So we already know that Mr. Jones's influenza test is positive. The team would then be able to start oseltamivir quickly. And for influenza, unlike for COVID-19, we have an additional opportunity to use chemoprophylaxis. If Mr. Jones's roommate or other close contacts are asymptomatic, chemoprophylaxis dose oseltamivir should be started. While on chemoprophylaxis, Mr. Jones's close contacts should be monitored for symptoms and testing performed if symptoms develop. By preparing for and quickly responding to respiratory virus illness, we aim to minimize spread within a facility. However, when a large degree of spread occurs in a facility, time-limited enhanced IPC measures may be needed. Your local health department can help your facility determine which enhanced control measures are needed. Enhanced control measures might include broader testing and chemoprophylaxis, cohorting staff and residents, temporary modification of indoor visitation policies, like encouraging in-room rather than common area visitation, universal masking, limiting communal activities like dining, and improving ventilation. We recognize the toll that any form of isolation takes on residents, so any additional restrictions should be time limited, and other methods to maintain connection, such as video chats with families, should be facilitated. The extremely important work that you do is also very, very hard work. And in recent years, recommendations for respiratory virus prevention have been changing so quickly. For today's webinar, we wanted to make sure that you are familiar with our current recommendations and most recent information for respiratory virus prevention, so that you can continue to provide the best care for your residents and patients and also protect yourselves. The strategies we discussed today do work, but they only work when we use them. It is our responsibility, all of us, to provide safe, high-quality care for those that are in our care. Today, we reviewed the residents and staff need updated COVID-19 and influenza vaccines, and for those eligible, RSV and pneumococcal vaccines. We discussed how to place symptomatic residents on transmission-based precautions while awaiting test results to reduce the risk of spread. We recommend testing symptomatic residents, which will inform IPC measures and treatment, and reviewed how to identify and use appropriate antiviral treatments for COVID-19 and influenza. Much of what we presented today can also be found in our Viral Respiratory Pathogens Toolkit for nursing homes, which we just updated last week. This webpage has guidance and links to key CDC resources. We also wanted to highlight the second bullet here, a new tool to help providers inform residents and families about the benefits of respiratory virus vaccination. It's a one-page fact sheet entitled Why Get Vaccinated? It's available in English, Spanish, and Chinese. We've also included a few other helpful links, including this second to last bullet on how to access free weekly COVID-19 antigen tests for long-term care facilities through ASPR, a program which is still ongoing, and also the details for the PAXIS program for free Paxlovid access facilitated by the US government that's going to be available through December of 2024. And with that, I'll hand it over to Dr. Jacob Slifka for Q&A.
Thank you so much. And thank you to all of our presenters, Dr. Twentyman, Dr. Patel, and Dr. Wallander. And thank you also to our team of subject matter experts who have been doing their best to answer as many questions as they can as they've been coming into our chat. But we did want to start with talking about a couple of questions that have come in about vaccines. So I'm going to turn to you for these, Dr. Twentyman. First off, are residents 65 years of age and older recommended to get more than one dose of the new COVID-19 vaccine, similar to last year?
That's a great question. And the answer is no, they're not. Right now, CDC does not recommend an additional dose of the 2024-2025 COVID-19 vaccine for people ages 65 years and older who are not moderately or severely immunocompromised. Now, of course, CDC and the Advisory Committee on Immunization Practices will continue to evaluate evidence, discuss that publicly in our ACIP forums, and update recommendations as needed. And by the way, all the recommendations for those with moderate to severe immunocompromise can be found at CDC's interim clinical considerations for use of COVID-19 vaccines. Thanks.
Thank you so much. And since we're talking about vaccines, there was a question that came in specifically asking about how long after infection someone should wait before getting a COVID-19 vaccine.
Thank you so much. People may wait up to 3 months after their symptoms of active COVID-19 disease resolve, or up to 3 months after a positive test, if they didn't have symptoms at all. Now, that's not a requirement, so no worries if a resident wants to be vaccinated sooner, but we do know that history of recent infection is associated with some protection against additional infections. So those are our recommendations right now.
Thank you so much, Dr. Twentyman. Let's move to a question on infection prevention and control. Dr. Wallander, what are the current recommendations for return to work post-COVID infection for healthcare workers?
Thanks. So CDC's COVID-19 return to work guidance for healthcare workers is the same as last year. And those details are still available on our website, though we do recognize that the URL has changed with some recent website updates at CDC. So healthcare personnel with mild to moderate illness who are not moderately to severely immunocompromised, which I think is most healthcare workers, could return to work after at least 7 days have passed since symptoms first appeared, and if a negative test result was obtained within 48 hours prior to return to work. If they're not testing, return to work test is not available, then the healthcare worker would remain out of work for 10 days until 10 days have passed if testing isn't performed. The individual in either case should have improved symptoms and it has been at least 24 hours since their last fever. And additional details are available for different illness scenarios, like if you have severe disease or immunocompromise on our website. And these recommendations are being reviewed by the Healthcare Infection Control Practices Committee, or HICPAC, as part of the updates for the guidance for infection control and healthcare personnel. And the HICPAC updates are also available on the HICPAC website. Oh, you're on mute.
Thank you so much, Dr. Wallander. Now, shifting to testing and treatment, Dr. Patel, I have a question for you about testing for SARS-CoV-2. So in this question, the facility is using antigen tests for SARS-CoV-2 and influenza. If the SARS-CoV-2 test is positive for a resident, do they need to do further influenza testing?
If the SARS-CoV-2 test is positive, it's likely that the patient only has SARS-CoV-2 infection. It's rare for us to see co-infection with SARS-CoV-2 and influenza, but it's really important to take a history and see what the patient's exposures were, just to make sure that there wasn't a known exposure to a patient who had influenza, in which case you might also want to test for influenza. And the other thing I will say is that it would also be very important to assess the patient's risk for severe disease if they do test positive for SARS-CoV-2, because if they do have a high risk for severe disease, which is really driven by age, so age greater than 50, especially 65 and older, even more especially 75 and older, they really should be considered for treatment as soon as possible.
Thank you. And we have been hearing, I think this is very important information, especially as we are getting into the season where we are seeing multiple respiratory viruses, or will be seeing multiple respiratory viruses in the community potentially, and so potentially in our facilities. Thank you, Dr. Patel. Dr. Twentyman, I have another question for you. This question is a vaccine-specific question and asking about how long we should be waiting between giving the last 2023-2024 COVID vaccine and the new COVID vaccine.
Thanks so much. Great question. For most people, the minimum interval between their last 2023-2024 COVID-19 vaccine and this new one that has just been recommended is 2 months. However, there are some important exceptions, including for those with moderate or severe immunocompromise. So again, I would encourage everybody on this call to refer to CDC's interim clinical considerations for use of COVID-19 vaccines for those exceptions, for those with moderate or severe immunocompromise. Otherwise, 2 months.
Thank you so much. All right, Dr. Patel, I have another. I'm going to jump back to you because this is a question regarding the use of antivirals. So it can be difficult to get blood work quickly sometimes in a facility, in a nursing home. Do you have any suggestions as to how antivirals can be used quickly that require, when they require dosing based on kidney function or adequate liver function?
I think it's really important to assess a patient's eligibility for antivirals before they even get sick. You know, it would be nice if we could take the time to review a resident's medical history and the drugs that they're taking and understand before they get sick what medication and what dosing of that medication would be best for them. That would preclude the need to do any testing in terms of kidney function and liver function, and also help us to start treatment soon after they become ill.
Thank you. If we have some of this information, we may, when people get sick unexpectedly, there may be less scrambling in that moment to figure it out, and we may be more quickly able to move on to using antivirals. Thank you so much. Now, I do want to get back to a couple more questions in the last few minutes, or well, maybe one more question very quickly for Dr. Wallander, an infection control question. When can COVID-19 PPE be discontinued for a symptomatic resident who tests negative for COVID-19? And Dr. Wallander, you're on mute.
We traded places. So thank you for that. We talked about how important it was to start COVID-19 or the SARS-CoV-2 based transmission PPE while we were waiting for test results. If the resident was tested with a nucleic acid amplification test, so that would be like a PCR test or a similar molecular test, a single negative test is usually sufficient to stop that COVID-19 PPE and transition to the more likely diagnosis. If an antigen test was used, a negative test should either be confirmed by a negative NAT or a second negative COVID-19 antigen test taken 48 hours after the first test before the PPE should be discontinued. And then if influenza is circulating in the community, symptomatic residents should be tested for both viruses, which will dictate PPE.
Great. Thank you so much for answering that. And I with this, can we move on to the last slide? And I want to thank again all of our presenters for speaking today and for answering questions. This concludes our Q&A section. And so we are now showing on the screen information for our continuing education credits, which will become available as soon as the webinar has completed. And with that, we thank you very much for attending today's webinar.